So I'll be introducing a new topic, new in our session today, but I believe that is already a well-known topic for everyone. That is the stroke hyperacute care. Okay, I have no disclosures. So as it was mentioned in the beginning, I work with the European Stroke Organization with their simulation committee. I'm at the moment teaching as well for the health science. So stroke prevention, stroke care, either hyperacute, acute, post-acute, and rehab, we can change and make impact in different ways. So I want to know something about our team. So when I mention our team is me and all the attendees that are here with me. So I want you to grab your phone or your computer. Okay, and I want you either to access to this website, www.menti.com. I believe that you'll not be able, if you are in UAE, you'll be able to use this code. I have this initial question. Are you a stroke nurse? So I'll be waiting for the answers. I know that it'll take a while. Just type menti.com and then use 5873-666. In that time, I'll be checking the chat. If there is anything for me. No, I need you to answer through the website, please. Because there is a few questions. Okay, the colleague that said that is not a nurse or a stroke nurse, are you a nurse? Which kind? Because I want to know what is your field. The website I'll put here, I'll type. So you can just copy. And the code I'm typing as well. Yes, www.menti.com, and then you'll just use the code 5873-666. Okay, I have already 11 people logging in. So I'll start to see numbers are increasing. I'll start to see your answers. You can start to answer and just stay there because then there is more questions. Code again, yes, 5873-666. Sorry, I was sending to Mustafa. Sorry. I put in the chat again.
Do you want me to put it in the chat for you?
No, I put it already. It was my mistake. I sent to you.
That's okay. Thank you.
Only notice now. So 24. Okay, not bad. So, okay. Great, great, great. Be fast, be fast. Time is running, time is running. And it's the end of the weekend. Interesting, interesting. Okay. Great. Anyone else? Anyone else? Oh, there is still people. Mustafa, do we know how many participants we have in our room, in our session?
Yeah, it's 166.
All of them.
Yeah.
Because I was not sure if it was the total between the doctors and the nurses.
I think this is, yeah, the total, yeah. And so in the nurses room, probably we have like 100 or 110.
Oh,
yeah.
Okay. So everyone, we are still on 41. So I want to know who is a stroke nurse. 41. It's funny if you don't answer the first, but I need you to answer the others. Guys, just to check if. No. Okay. So remember, this question is stroke nurse. Okay. So we'll be going to the next question. Okay. So I'll just take a note. 32 are not, and 11 are yes. Oh, the number keeps increasing. Okay, we'll be moving. So the next, for the ones that they answer no, where do you work? Ooh, okay. Good. So the ones that they answer, they are not stroke nurses. Triage, great. Great. Critical care, oh. Interesting, because there is strokes, in-house strokes. Critical care, perfect. Oh, 2 colleagues in the emergency medical services. Great. And some of you probably remember one of my presentations, if you are from Kuwait or Iran. I don't know if we have anyone from Africa, from Kenya. He will remind me. So 44, 45, okay. Okay, this is great. So our session today for the rehab, it will be really useful for the medical ward and the skills for the phases before. Great. Really, really good. I wish I could know all of you. So just go on. No worries if you rest by mistake. Physio. Great. School health operations. Okay. Perfect. Great. I think we'll move to the next one. I think this takes just a little bit of time to move. So for the colleagues that they work at ER, do you treat the patients at the CT scan? And when I mean treat, is you thrombolize the patient in the CT, or you bring the patient back to the ER? Right. In the you thrombolize in the medical ward in ER, okay. Okay. You bring the patient back, okay. There is no right or wrong. No, it's just I'm too curious. Great. After CT patient, bring back to the ER. Great. Perfect. Great. Great, great, great. Ooh. More. 42 answers. I need more. I'm really curious about this. Great. 45. I know that some of you probably cannot reach in ER, bring patient back, reach the website. Okay, right. So let me go. So 35 in ER. Okay, just taking my notes. So I believe that by this time, everyone is able to answer this question. And then we'll move forward. I think there is. Let's see. I'll just be checking for the ones. Yes. Great. I can see that some of you recharged well the batteries during the weekend. Great. Perfect. Okay. Great. I believe that this was the last presentation. Perfect. So now I know my team. Great. So some straight facts. Paula and Sarja, they already mentioned, and we already know this. So stroke, yes, is a medical emergency. And the stroke occurs when the blood supply to one of the areas of the brain is blocked or reduced. It can be from different ways. And this occurs because there is an insufficient supply of blood to the area of the brain. So the blood doesn't reach, so doesn't give oxygen and nutrients. So that part of the brain will be affected. And the part of the brain controls part of the body, it will be affected. So, and if the blood flow, so the blood circulation is not restored, the brain tissue will die, causing permanent disability. This is why we mentioned that time is brain. And it's why stroke is emergency, because if the brain is without oxygen and nutrient supply, without blood supply, that brain tissue will die. And per second, there is so many brain cells that they die, okay? So, and connecting with the 2 sessions before, the scales and rehab, where can we gain time? Because if we treat stroke faster, our stroke patients, they have more rehabilitation potential. So they can recover better, faster, and go home, back to their community, back to their job, to their life, with their quality of life. So regain their previous function. So one of the ways that we can treat the stroke, if they are still in the time that as per the international guidelines is still around 4.4 hours and a half. There is some hospitals that they do some trials. A few new recommendations will come out soon. So if there is a clot, if the stroke is not a bleed, we can thrombolize the patient. So we can give RTPA, and this will help to dissolve the clot. And dissolving the clot, the brain flow will be restored. So the blockage will be gone, and the blood keeps flowing as normal. So one of our challenges, and our colleagues from the emergency medical services, our colleagues from the ER, know this better than us because you feel this every day, is the poor recognition of the signs and symptoms. At home, for example, when they call that someone is having something, normally they don't recognize as being a stroke. They say I was not feeling well, I tried to wake up, is the slurred speech, or even they bring to the hospital through the normal process. So this takes us to the second point, that is the inappropriate or delayed medical assistance. Some of the people, they just think, oh, I don't feel well, just go back to sleep, I'll see if I'll get better. So we lose the time. Another fact why thrombolysis is still a challenge is the poor triage and the early assessment. And it was important when Paula mentioned the scale, because in the triage, for sure, the colleagues from the triage is a challenge. When you receive the patient, if you don't have a pre-notification, it will be hard for you to go all through the questions, and especially if you use the Manchester triage, it will take time until you reach there. Another challenge is due to the lack of communication with the receiving hospital, and we'll be talking this later, and the delayed arrival outside of the time window to the stroke center, because I know some of your reality. Some of you don't do thrombolysis, you don't thrombolize, you don't have the medicine available in your hospital, or either you don't have the CT scan to know if he's a bleed or not to the side, and you need to send the patient to another hospital or a main hospital. So when the patient arrives, it's already out of the window. So these are our main challenges. So emergency stroke care, so how we can try to prevent, reduce the time, has a 4-step chain. So there is 4 steps that all of us, we can work on this. That is general public awareness. For example, I'm really happy that we have someone from the school. So we can share with your colleagues, with your students, and remember, your students, they'll go home because they belong to a family. They'll go home with creating some awareness in the school, university, wherever. He will create awareness. They'll go home, they will share the information with their family, then with their relatives, then relatives with the relatives, with the friends. So you can see how it's like a network, how it will spread. The same now with the pandemic. So awareness, early recognizing the symptoms, okay, and how to act properly. There is some countries, they did already activities. I know that Saudi Arabia, they have a great video on this already in Arabic. So just ask us or search for some tools to your stroke society, through the our angels link. The other step, the second, is the emergency call center. So when we identify that something is wrong, when we call the 999 or 911, it depends the country. It will be different. Then if we take our relative to the hospital, or we wait for the emergency medical services, the ambulance. I know that some countries, the emergency medical services are private because the public ambulance, they are really a small number of vehicles and they cannot provide care on time. So this will depend country by country, and it will be a challenge. And the last one is to have a quick triage, assessment, imaging. So we have the CT scan, to have a stroke team, and to have a diagnose, a proper decision, and to do a proper treatment on time. So for stroke, our main priority is transportation and treatment, okay? So with hyperacute stroke care, we want to increase the thrombolysis rate. So if the patient is fit for thrombolysis, we want the patients to receive on time, reduce the mortality because we are treating stroke, decreasing the length of stay because if we do it faster, the patient will have less less sequels, and reduce the long-term cost because the patient will go back to work, will go back to their normal life. Okay, so these are the main benefits, and how we can do this is having a proper and the best care and approach in our hospital facilities, in our healthcare system, and in the country. So as I mentioned, these are the 4 steps. So the pre-hospital phase, there is an early recognition, there is a on-time treatment, then there is a discharge and a rehabilitation plan, and or the patient is transferred to the local, either to a medical ward where he can continue the rehab or to a rehabilitation facility. So, how many of you have already a stroke pathway in place? Now there is no up and down questions. Some of you probably have already a stroke pathway because we did some trainings for sure, and our stroke, our angel colleagues did a great job with your hospitals. So I believe that some of you have already the stroke pathways, and I wish we have time to discuss this, but we need to move. Okay. So for our colleagues, I know the emergency medical services colleagues, they are here. This is great. I hope that you have the pre-notification, and if you have it, please share in the chat your experience with that, with the ER, which kind of information. Unfortunately, we don't have enough time for that. For the other colleagues, the nurses, the ones that they said that they are not stroke nurses. A stroke nurse is someone that takes care of a stroke patient. You don't need to have a certification. You don't need to work in a stroke unit. In ER, you are taking care of a stroke patient, and you are learning, you are gaining skills and knowledge how to take better care of your stroke patient. So yes, you are a stroke nurse. The same in the medical wards and in the ICU. Okay, so for sure, your pathway includes the role of the stroke physician if you have it, and this is at the triage, so when the patient arrives. And here is what I want to discuss with you, because if there is pre-notification, one of the things, and the emergency medical services, they'll try to do the maximum that they can do in the ambulance on the way to the hospital. So it will save time at the hospital. Point of care, blood tests. This is what we should have at the emergency, the ER. First of all, to recognize, to use the fast, right? And then this is the urgent things that we need to save time. So how can we reduce the door to needle time? And please type in the comments your door to needle time in your hospital, please, okay? So the ambulance pre-notification. If you arrive, and this is our main challenge, if you do thrombolysis and if you have a CT, I know that some of your protocols, the patient arrives, needs to go through the normal triage, needs to see the doctor needs to suspect of a stroke, and then order the CT. The patient is mobilized to the CT. The CT scan is only one, is busy, the patient waits, and you can imagine the time that we already spent here and the brain cells that they already died. So please, your physicians, your doctors, they are on the other chat room having the same discussion. So the main idea is for you to go back in your next duty and to have a brainstorm how to save time. Then the POC testing. we're talking about this, and to treat at the CT scan. So this is the main difference between pre-notification if you have it, if you don't have it, the triage. So without pre-notification, the triage, Paula, she mentioned about the FAST. I'm mentioning about the BFAST because there is 10% of the strokes that we cannot detect, identify. Okay. So at least using the BFAST, we can add to recognize that 10% that they used to be missed. That is the balance, because some patients they are having a stroke, and there is no weakness on the legs. There is no weakness on the body, and the vision, the blurry vision, diplopia, and myopia, that if we use the FAST, we don't recognize, right? So this can be something that you can improve if you are not using at the moment. And during the triage, what is the relevant medical history that we should ask to save time? First of all, we need to rule out the stroke mimics. Hypoglycemia, we mentioned a few. Then what we really need to know, and remember, one of our previous speakers, I think it was Paula, she was mentioning about the weight, because without the weight, we cannot calculate the dose. And another thing is the onset of the symptoms. So is the last time well seen, okay? If the last time well seen, it was last night when the person went to sleep, we don't know what time the stroke started. So the patient will be already out of the window. So for our colleagues of the emergency medical services, if they can do as much as they can before the patient arrives, then when the patient arrives, you just endorse to the nurse. I know that sometimes you endorse and they still repeat. This is something that you guys can work as a team and discuss in your protocols. So oxygen saturation, because here we can prevent a few complications: blood pressure, IV access, the glucose. If there is a pre-notification, the patient is already in the system. And then when the patient arrives, goes direct to the CT. And here it helps because the time consuming in the hospital, most of the things are done, it's just an endorsement. And here you can take the patient direct to the CT. There was something mentioned before, that is the consent. So this is important and depends the country to country. Some countries, because it's a medical emergency, we can go straight. We are covered as a healthcare facility, physicians and nurses, everyone. Some countries, they are not, and they really need to take the consent. So please have a look on this and make sure that this is part of your protocol, your pathway, the consent, if it's needed or not needed, okay? So, and we follow as well, this is still in ER, okay? There is, I will check with you the contraindications and management. So first of all, have IV access, oxygen saturation, there is the recommendations, okay? The blood sugar, there is the recommendations of the normal range, and the blood pressure. So here the blood pressure. So we need to be careful if in lowering too fast. So it's not recommended to do it. I believe that some of you have already experienced, if you work in ER, if you do the thrombolysis, about this. The patient position during the hyperacute phase, because remember, if the patient is still in the ambulance stretcher, or if you spend time moving the patient to the stretcher in the hospital or the bed, we need to be careful how we mobilize the patient, okay? So in order to avoid some head injuries, the bed should be at least, or the head, 30 degrees, okay? And normally we need to pay attention to the weakness side. The patient might not have sensation, neglecting that side, subluxation, so we need to prevent this part because we are doing everything in a rush. So the medical history, and what I'm putting here on the right side of the screen is the documentation, because we need always to document, okay? So if we are lucky and our patient arrives directly to the CT, we are saving at least, you can imagine, more than half an hour, right? More than 30 minutes. So if the patient goes directly to the CT, and this can be some information that you can use from Angel's website to change your practice if you still don't do it, okay? So taking the patient direct to the CT can reduce the in-hospital delay. We don't lose time transferring from ER to the CT room and decrease the door to CT and the door to needle time. Some of the buildings, they have the CT scan on the other side of the hospital. Some of the hospitals, they have the CT scan in another building. So you can imagine there is an order putting the patient back in the ambulance and taking the patient back. Okay, so this needs to be in your protocol. I know that few places they have already the stroke code when it's activated, that the CT scan radiology, it's already waiting, it's a priority, okay? So one of the things that the international guidelines, they recommend is when you take the patient direct to the CT, so EMS arrives directly in the CT, the stroke team, it's already there at the CT room, as you can see here. Sorry, on here. As you can see here, the CT, the stroke team, it will be already there. So they'll do a quick neurological evaluation. Can be just to be fast or the fast, just to confirm. And there is no delay. They'll check again, probably the blood pressure, make sure that there is a cannula while they are waiting for the room to be ready. And even the emergency medical services colleagues, they can help during this. And there is no delay. Then there is no delay in interpretation. Then you as a nurse, you still can do lots of things while the physicians, the doctors, they decide, because they will discard if there is a bleed. While they are still deciding, if the patient doesn't have a cannula, you can put it, recheck blood pressure if it's high. If it's too high, there is the standard management to give medication, okay? And then you can go through either the consent and the contraindications and the dose, and preparing the dose mixing if you have already, because some of the hospitals, they have the medication, the RTPA is still in the pharmacy, needs to be dispensed. Okay. So let me move. So POCT, this is a big question. What we should do, right? So, what do we need to know? Let me just check. Yes. So what do we need to know to thrombolize the patient? Remember, our mission is to treat the stroke. So we need to make sure there is no bleed. This is through the CT scan and its decision. And from our side, from nursing side, we need to make sure that the requirements, everything is ready. So the only thing that is urgent that can change the decision of thrombolize or not thrombolize is the blood sugar, okay, because it's to discard a mimic. And if the patient is on any fibrinolytic therapy like warfarin if we know that in advance. Sometimes, because there is the risk of bleed, some ERs, they need to send to the lab and it will take too longer. Some ERs, they have the finger drop that it will be faster. So basically, our priority is the blood sugar for the lab tests. Remember, what we want to do is treat the stroke. After, we will work on the consequences, but to thrombolyze is just to stop the block of the blood flow. So our priority is blood sugar, nothing else. You don't need to take time to check hemoglobin, creatinines, because the CT scan is without a contrast, so there is no issues, okay? Then everything, CBC, electrolytes, cardiac markers, they are important, but they shouldn't delay the thrombolysis, okay? They shouldn't delay. If it is delaying, it's not a priority. So the priority is the blood sugar. Another thing, documentation again. All of these documents that I'm showing here, they are available in Angel's website, okay? So can help you. I know some of you have already your own documents, so you can change, adjust, or if you have electronic medical records, you can integrate. And remember when I asked some of you who treats at the CT scan and who doesn't treat at the CT scan. So if you don't treat at the CT scan, you will bring back to the ER the patient. So again, spending time bringing the patient back, right? So why is recommended by the international guidelines to treat at the CT scan? And again, this is information, evidence-based, that you can use to improve your services. Decrease door-to-needle time, reduce the hospital delay, and we don't lose time bringing the patient back to the ER. And how we can do this? You are imagining now, but my CT scan, my radiology, there is nothing, just a machine. So there is the stroke bag. I will give you an example. So in the stroke bag, you will have already everything. Some of the hospitals, you will need a policy to create a stroke bag. You'll need a checklist. Everything is available in the Angels. Some of you, I believe that you have already the stroke bag, right? So if we want and if we can to treat the patient at the CT, there is no barriers, nothing that will make us to lose time. Stroke bag will have everything. There is even a checklist. The RTPA, it will be inside. And during the time that the physicians are analyzing and deciding, you can already start to mix into the calculations. Because the stroke bag contains everything that you might need. And please make sure that you have there the checklists and the calculations. So I want to show you something. You have all the checklists, you have already the calculation, everything can be there. You can download and see the website. The consent, even the calculation, you don't need to make the calculations for the dose. It's already know the weight and know what you can put the remaining 90. So if you still don't have the bag, ask to your angel contact or representative, or you can improvise. Can be a box, can be a bag, any bag, and then you just organize, like we have the transportation bags. So creativity, okay? So then there is a therapeutic decision making, and the decision is taken by the physicians. We just need, as nurses or as health aligned workers, this is how we can help them. It's to help in the proper diagnosis, and for this we do the POCT. Okay. We exclude the bleed through the CT, assessing the severity. Again, important, the scales. If you are already familiar with the scales, you just, while the patient, they were doing something, you already saw the patient. So straight away you can say NHISS 5, 10, whatever. And you can remind about the contraindications, blood pressure, risk factors, and consent. And at the same time, controlling the environment, calming the patient, because one of the things that sometimes we forget is the patient. Everything is going around. And this is something that you can practice with your colleagues. So contraindications, just quickly. So if there is a risk of increasing the bleeding, the severity, the age, the time of onset, and if the patient is not stable, first we need to make sure that the patient is stable. Okay, so Paula already spoke about this, so I will move. And then I just want to do a quick reminder about documentation. Okay, we need to do a proper documentation. This documentation is important through all the journey of the patient, because all the documentation during the emergency, during the treatment, okay, before by the nurse, and after. So what did we do? And this is important when we transfer the patient either to the stroke unit, to the medical ward, ICU. Okay, there is for the physicians as well. Inclusion, exclusion criteria, you have the checklist. Okay, you can have everything, so simplifying everything for the physician. One of the things that I want to suggest to you, so normally we go through a simulation. Some of you did already simulation with me, so we will have a situation, a case scenario, and we do it. Of course, now virtually is not that easy. But please go back to your facility, to your service, and go through all of these steps. You can organize a simulation with your colleagues. Try to do roles allocation and someone to observe. If you don't have a protocol, suggest to create one using the guidelines, and practice. It's like how we do it at the school. We keep practicing until we get experts, and we always do it right, but we can always do it better, saving the time. Even if your door to needle time is 70 minutes, you are already doing well. You are treating the patient, but analyze your pathway. Can you save 10 minutes to do it in 60 minutes so you can save more brain? This is the biggest challenge. And now I will have a look in the comments. Thank you so much.
It was very comprehensive because I attended the majority of your session. We are done with the neurology and medicine session. It's really a great pleasure what we had today, and I think it was well organized and it went smooth. I would just ask the audience if they have any questions. They can write them down. I think I have one of the questions here directed to you. Um, we received cases with other symptoms than BFAST, like dizziness and headache, and the cases are BFAST negative. After CT done already, stroke was diagnosed. So do they recognize stroke with other symptoms, or do you? I think the question is that BFAST, would it always work, or do you suggest to keep an eye on other symptoms?
Yes, no, I am. So the recommendations, international recommendations, either from American Heart and Stroke Association and European Stroke Organization, are to use as a quick triage fast or be fast. And then is the clinical decision. Is we need to assess the patient. And sometimes, unfortunately, when there is no evidence, there is even can be a TIA, or we cannot recognize. And this is how it's important, the research and to report these cases. For example, this case that the colleague Ali is mentioning, it will be interesting to analyze all the symptoms that they were assessed during the triage and to see what it was described and what we missed. So for next time, we can add that. And it's true, reporting this, that guidelines change, because the guidelines, we need to have a huge number, significant number, so we can change guidelines. But so far, the guidelines is fast, be fast, and the clinical assessments and the patient history.
That's great. That's great and clear. If we have any other questions, or if you see any questions in the chat box before I join, because I cannot see them all.
I'm going up. So I can see that door to needle time 60, less than 60, some cases, perfect. Some of you have already stroke protocols, great. But remember, keep doing simulation, keep training, because, and remember, some of you that join some practical simulations, the communication between the team, the doctors, if the nurse spoke with the doctor, with the family, with the patient, if they did endorse, the information that they received from the EMS colleague, because we have some testimonials, some experience from the EMS that sometimes the nurses in the hospital, they don't listen them. So this is the teamwork, okay? And it's important because everyone is there for the stroke patient, for them, and we are a team. Like it was mentioned in rehab is a teamwork as well. We cannot work together alone. Alone as a nurse, I cannot save the patient. I cannot treat the stroke. The doctor alone cannot treat. Radiologist alone cannot treat. So it's a teamwork. So simulation and trainings.
Yeah, one question. If one element of BFAST is positive, do we consider stroke activation?
Yeah. If only one, we only need one to be positive. That is a good question, Hamed. Thank you. So we be fast or fast, only one is positive, straight away activate stroke code. Doesn't need to match all of them. Only one, even sometimes the dizziness, okay, there is some dizziness takes us to a balance impairment activate, because it's better to activate and then it's not a stroke than to recognize later on. Great.
Okay, so until I make some closing remarks, if you have any questions for Raquel or Miss Paula or Miss Sujata, just put them in the chat box. Just for all the audience, you will receive links on your emails, on your registered emails with the survey, just to measure the meeting KPIs and to learn from you what are the topics that you need us to integrate in our next Angels Academy sessions. So this is a survey for the purpose of improving our agendas and upscaling our topics up to the subject matters that you are interested in. And you will receive another link with with access to your CME certificates, and you will be able to download them and save them and print them as you wish, depending on the number of minutes or hours you attended in today's meeting. And one last important announcement: you will receive as well an email with a link to the Angels Virtual Academy original platform, where you will find all these materials archived. Today's sessions will be archived there. You can go all across the platform, because you will have several parts with experts' opinion videos from everywhere across the globe. You will have uh, the option to experience augmented reality using your mobile phones and watching the certificates of excellence that were extended to the centers within the region. You will also have the chance to watch today's sessions in the archive. So we will invite you all to register if not already done before. You will be able to register and access the platform, and it's just a new and upgraded and upscaled Angels experience. So I think we are done for now. Thank you very much. If you have any queries at any point of time, please don't hesitate to contact me by email. Thank you again, Raquel, Paula, and Sujata. You always bring the difference, and you always make our meetings much richer and much more impactful. And our thoughts are always with you and with all the frontliners who make the difference in our lives. So I think we are good to go, and a big thank you message to all of you.